Welcome, and thank you for tuning in to Derm Docs, powered by LiveDerm. This marks the 6th and final episode of our ongoing series, a program on JAK inhibitors for atopic dermatitis, hosted by expert dermatologist Dr. Christopher Bunick, Associate Professor of Dermatology at Yale University in New Haven, Connecticut. Our 6th episode in this series, Achieving More, How and When to Switch Systemic Therapies in Atopic Dermatitis, features Beth Sweney, Physician Associate Certified and co-founder of River City Dermatology in Grand Rapids, Michigan.
Hi, I'm Dr. Christopher Bunick, Associate Professor of Dermatology and Translational Biomedicine at Yale University School of Medicine. And I'm really excited to have all of you listeners back for the 6th episode of our podcast series program on JAK inhibitors for atopic dermatitis. And today I have a special guest, Beth Sweney, PAC, to talk to us about achieving more, how and when to switch systemic therapies in atopic dermatitis. Beth, can you take a second to introduce yourself to our guests?
Yes, of course. Thank you so much, Dr. Bunick, for having me. It's an honor to be here to chat AD and to talk about, elevating the standard of care, something I'm very passionate about. So for those of you who don't know me, I am a PA specializing in dermatology and then subspecializing in inflammatory skin disease, psoriasis, eczema, HS, all the fun things. So I see it all day, every day. I own the dermatology half of a combo derm room clinic, so work hand in hand with my fellow rheumatologists. That's been very rewarding. So really happy to be here talking about how do we elevate care for AD.
So there you go. Beth has extensive clinical experience in dermatology and expertise in managing atopic dermatitis. And I agree with you, Beth. I can't think of anything more exciting than just talking about atopic dermatitis. Who needs coffee when you can talk about AD?
That's right.
So I think one of the first questions I have for you is this concept of therapeutic inertia. What does that mean to you? And how would you educate our colleagues about its importance or what it means to dermatology patients?
Yeah, the inertia, when it comes to AD, patients really do want results and they want to get results quickly. The burden of atopic dermatitis is very severe, right? And it's not always one that we can see, but there's definitely been this resistance towards treating our AD patients with more advanced systemic medications. So there's this lack of movement, right, for that patient to get to therapy where they can really see the results and feel the results, right? Especially that itch relief that they so long for. So I think that's definitely a huge need in the AD community and something that we need to do better to encourage our fellow providers to get out of that comfort zone, step up to the plate, right? Go to bat for that patient that's suffering with AD. And I think part of it is really recognizing the need, right? That's out there, that need that's not being met. We in dermatology are super visually oriented, right? So if we, can't see it, that determines a lot of how we categorize severity. But when it comes to AD, a lot of what that patient's experiencing can't be seen with our eyes. So that's where we really have to dig in and collect data from the patient on their experience, their lived experience that matters.
So Beth, I like what you said about the needs of the patients, because that is exactly what the AHEAD recommendations are geared towards. So for those that haven't heard about AHEAD was sort of like a task force or committee. It stands for Aiming High in Eczema and Atopic Dermatitis. And it's really a task force designed to lay out new standards of care, optimized standards of care that we, the clinicians, should be trying to achieve with our patients. But as Beth just said, what is the need of the patient? The need of the clinician is what we see, getting that skin clear. But what the patients have told us is that they need the itch gone, and that is the biggest factor for improving their quality of life. So Beth, when it comes to the AHEAD recommendations, what exactly are they telling us are optimal treatment targets for our atopic dermatitis patients?
So for the AHEAD recommendations, they really want the patient reported outcomes to be also in line with physician reported outcomes, right? And our physician reported outcome is going to be that easy 90 to 100, right? That optimal disease control that we can see with our objective assessment. But then they also want an itch score of 0 or 1. So that patient reported outcome that comes from that patient, they want that itch score at a 0 or 1. So the combination of those two items is what the AHEAD recommendations want.
That's exactly right. So when you have a patient-reported outcome that's achieving little to no itch combined with the clear skin that we, the clinicians, want, what that ultimately gives the patients is minimal disease activity, right? And that's what you are speaking about. We want our patients to be the best they can be. And one of the most important pieces of data for me in 2023 was evidence showing that the quality of life of atopic dermatitis patients tremendously drops if their itch just goes from a 0 or a 1 to a 2 or a 3 on that 10-point scale. And I didn't, Beth, in your practice, if you had a patient that went from an 8 on the itch scale to 4, I mean, I think you probably thought you did a really good job. And I did. I know I did. But that's not what the patients tell us.
That's right. No, you're absolutely right. And this reminds me of a very humbling experience that I had in my clinic. And if anybody can learn from somebody else's humbling experience, I recommend they do it. Right. So it was like November of 2020, and I thought I was amazing at my job. I thought, you know what, I see psoriasis and eczema all day, every day, and my patients are doing so good. Everybody is really well controlled. I decided to collect my own patient-reported outcomes so that I could have patients tell me how good I was at my job, right? And I'd have quantifiable data that said I was this good at my job, and I was going to use that to get a raise. But you know what? I started collecting poem scores on all of my eczema patients, and I had a really rude awakening. I was not as good at treating eczema as I thought I was. Here was a patient sitting across from me. They had almost clear skin or completely clear skin. They were telling me their itch was a 2 or a 3. And when they started at an 8 or a 10, that was pretty darn good, right? And I'm writing well controlled. And lo and behold, 3 out of 4 of those patients were still walking out the door with significant burden of eczema. But I was writing that they were well controlled. So there was a big disconnect, a very humbling experience for me, right? To realize that, holy cow, I was missing the mark. So it's really significant when you are collecting data that you see with your own eyes that causes you to have this kind of wake up that, okay, maybe just a 4-point reduction in itch shouldn't be our standard anymore, right? Maybe like our patients are telling us they need better. And they're still walking out the door with burden of eczema. And that's not good enough for me because that's not good enough for them.
Yeah, I love what you just said. And you said a buzzword for me, which was disconnect. So that's exactly what all of this is about, right? The therapeutic inertia, that the fact that patients are having trouble going from average therapeutic response to a therapy that gives optimal treatment response. We don't want therapeutic inertia. We want to get those patients on better treatments that are going to actually work. And what the AHEAD recommendations are telling us, right, there's the optimal treatment outcomes, as you said, the EASI 90 and itch 0 or 1. More moderate treatment outcomes are sort of what we used to think about, like EASI 75 and a little bit less itch control. But we don't want just moderate. We want optimal treatment outcomes for our patients. And this means that really the treatment response is inadequate if the optimal treatment targets are not met within 3 to 6 months. And if you're not achieving that, your patient's not achieving that, you really, as the clinician, should be thinking about treatment modification or dose escalation, depending on the therapy your patient's on. And I think that's really the crux of the problem. And the patient-reported outcomes are showing this quality of life is really linked to itch. And Beth, sometimes if you just go from that itch of 1, 2, or 2, some of the measures, depending on which PRO you're looking at, it can be 40, 50% drop in quality of life. And this data makes me want to be a better doctor because imagine I was the patient and my doctor settled for the average medicine.
Absolutely right. Hands down, 100%. It's so motivating to identify a need, right, that you didn't know was there before, and it motivates me. It's humbling, but then it also makes me want to step up my game. What can I do better? Right? My role is to identify gaps and fill the gaps. So there is a gap here, and I need to fill that gap and make it happen.
So speaking of gaps, let's talk about the Target Derm Registry for Atopic Dermatitis. In particular, what this data that I want to talk about is looking at is the long-term systemic therapy in moderate to severe atopic dermatitis. Those patients who are not achieving either a moderate or optimal treatment target for either skin clearance or itch. And these are patients that have largely, about 80% of them, have been on dupilumab for up to 12 months. And Beth, can you walk us through what did this data tell us, and what does that mean for the concept of therapeutic inertia?
Okay, so what the Target Derm Registry really shows us is that there's a significant amount of patients that aren't meeting either target, either in skin clearance or in itch relief. So there's about 80% of patients that aren't able to achieve either, right? Skin clearance or itch relief. And they're also not even meeting those, moderate or midway target goals either. So it's definitely highlighting a need for better assessment of control of disease, as well as, identifying the real inertia going on as well, even within this group of patients on advanced systemics.
Yeah, it's pretty astounding, Beth, that you have such inadequate response in this database or in this registry. Who would think that being on 80% of these patients on dupilumab for 12 months, who would think that about 80% of them are not hitting an optimal treatment target? I mean, for skin clearance, that just astounds me, because that's not what dermatologists believe, right? They believe that dupilumab is going to clear most of their patients, but this data suggests that's not true. Only about maybe about 70% are going to hit the moderate target, but only about 20% are hitting the optimal target. And I think that this is for skin clearance, and the itch is even worse in terms of hitting those goals. And so I just think that we as dermatology providers have to be aware that atopic dermatitis patients may be suffering more than you think on a systemic therapy, and you cannot be afraid to switch. And what have your patients told you about quality of life in terms of when is it time to switch? How many patients are coming in and saying, I really am not sleeping, I am so itchy, this therapy isn't working? Do you hear that every day, every week, every month?
I hear it when I ask about it. Right? I have to initiate that conversation. Patients are coming in, and, if I just let the patient lead the discussion, they're probably going to walk right out the door still battling their eczema. And that's the change that I've had to make since I started collecting PROs. I'm no longer letting the patient lead that discussion. I'm specifically asking if they're rating their itch any higher than a 0 or 1, I'm asking deeper questions. Is this impacting your sleep? Are you able to focus in school, right? Can we do better for you because you deserve it? So it's all about being comfortable and confident in having that conversation with your patients, because they're worth it. And their AD, while it may be better is not always good enough.
Yeah, Beth, I really like what you said about that we have to take initiative and own that conversation, and particularly talk about itch, sleep, other quality of life metrics, not wait for the patient to talk about it, because what you just said, many patients don't bring it up. And I think this is an area where I've improved as a physician, is actually understanding I need to do more on this quality of life aspect of atopic dermatitis. So I'm glad to hear that's what you're doing in your practice, because I'll be the first to admit, 3-4 years ago, I was not doing this.
I was not either. Yeah.
And I guess this is what they call it the practice of medicine, right? We're forever improving ourselves.
As we should be. Absolutely.
As we should. All right. So, Beth, let's kind of transition here to an important clinical trial that has put these AHEAD recommendations to the test. And what do I mean by that? Well, we're going to talk about a level up clinical trial that actually used as a primary endpoint this stringent optimal treatment target, simultaneous achievement of EASI-90 and itch-01. Beth, can you walk us a little bit through the design of the trial? What is period 1? What is period 2? And just explain to people kind of the setup, and then we'll dive into some of the data.
Absolutely. So this level up study was a head-to-head comparison of upadacitinib, JAK inhibitor, versus dupilumab, an IL-4 and 13 monoclonal antibody, in patients with moderate to severe atopic dermatitis. So these patients, and what I find fascinating about this study is that this study recruited over 900 patients, and they recruited it a year ahead of schedule. What does that tell us about the need that still exists in this patient population with all these therapies, right? That really highlights that there is a significant need out there, that they were able to get over 900 patients a year ahead of schedule, right? Holy guacamole. That's a significant need. So definitely something we need to call out, right? Because that's that gap, right, in action. So then when they set up the study, they randomized patients 1-to-1 to be on dupilumab per the label or Rinvoq 15 milligrams. The study period 1 was 16 weeks long, and they began assessing patients at the week 4 mark. And there was some dose escalation because we have that ability with upadacitinib. So if patients starting at week 4, if they hadn't achieved an EASI-50 or a 4-point reduction in itch, they were required to be dose escalated to 30 milligrams, right? Now that was a standardization because this was a very large clinical trial across the globe, 30 countries, right? They had to make sure everybody was doing everything the same way. So it was standardized in this trial. And then starting at week 8, if they hadn't reached an EASI-75 or a 4-point reduction in itch, they were required to be dose escalated to 30 milligrams. And if they fell below that standpoint at any point in time, then, they were dose escalated up to that 30 milligram dose. And then they were fully assessed at week 16. This study is purely monotherapy. So if patients at any point in time had to use a topical steroid, they were considered a failure. Right? Can you imagine in the real world if, if we were considered a failure if a patient put on a topical steroid? Holy cow, right? I'd fail all the time. But this is a clinical trial, right? These are their failure standards. This is a very stringent criteria. Purely monotherapy, drug against drug. Let's see how they do, and let's see if we can raise the bar and elevate the standard of care in outcomes in AD. So very interesting data that was collected, the most stringent data, the most stringent primary endpoints, right, for any clinical trial in atopic derm yet, which is exciting, right? Right. This really is, us putting our money where our mouth is. Let's see where we can get patients.
So Beth, you're exactly right. The most stringent endpoints ever used in an atopic dermatitis trial. So what did they find? What did the trial show at the end of period 1, which is the first 16 weeks of the trial?
Yeah, so at the end of the first 16 weeks of the clinical trial, they found only 9% of patients on dupilumab were able to reach that co-primary endpoint of the simultaneous EASI-90 to 100 and NRS of 0 or 1. And more than 2 times more patients were able to achieve that outcome on upadacitinib. Either 15 or 30 milligrams. I believe the number of patients that achieved that, it was about 50-50 split. We're on 15 versus 30. One in five patients hit that simultaneous endpoint on upadacitinib. That's amazing, right? So go ahead.
And the statistical significance was as early as week 4, the separation between upadacitinib and dupilumab, which tells us, Beth, what we, I think, already know about oral JAK inhibitors is that rapid onset of action.
Absolutely. And the thing, if you think about that week 4 mark, that statistical significance was reached just with that 15 milligram dose because patients couldn't be dose escalated until after that 4-week mark, right? So that we have already stratification on just that little low dose, which is really cool. But it makes sense when you think about mechanism, right?
Actually, that's a really, really good point, Beth, about the fact that even that achievement at week 4, that statistical significance, you're right, it is. It's the 15 milligram dose. So I wanted to circle back to something you said a little bit earlier, and that was the ability to dose escalate at week 4 and week 8. And I think that buried in this period 1 of the Level Up trial is a very important answer to what a lot of clinicians ask. When and how should I dose escalate? Well, the answer is, as early as week 4, if your patient's not achieving EASI-50 or a 4-point itch reduction. And at week 8, if they're not achieving EASI-75 or a 4-point itch reduction, you can dose escalate there as well. So it's not like you're waiting 4-6 months to dose escalate. You can do it at 1 or 2 months, depending on how the patient's responding. And so I think that was a nice little tidbit buried in this trial.
I think so too, but I'm even more like, per the label, it only says if an adequate response is not achieved. It doesn't say that you have to wait X number of weeks, right, before you can increase. So I'll even see a patient back in 2 weeks if I'm really worried about them, right? And, if I need to bump them up whenever I need to bump them up, right? That's the beauty about this medication is that per the label, we have the flexibility to treat the patient like the individual they are with the disease that they have, right? Instead of giving everybody the exact same dose regardless.
Well, I think our dermatology providers have to have the confidence to want to switch and take care of the patients in terms of how quickly are you going to change? How quickly are you going to say, you know what, this is not working. We got to go to another therapy or another dose. But that is, again, we're circling back to the therapeutic inertia concept. It's hard to sometimes just say, nope, we got to go a different direction. It's easier said than done.
That is so true. Familiarity with the medications will help bring confidence, right? Exactly. I really think, and I say this all the time, the JAK inhibitors are the future. And a patient's going to sit across from you someday, and the only thing that's approved to treat their condition is a JAK inhibitor. And if you're not prepared to have that conversation with them, they're going to find someone who is, right? Like it is just a fact of life. So we need to start getting our feet wet with these medications, if we haven't already, which I'm hoping that there's been some buildup because these are not new medications, right? But we need to start getting our feet wet with these medications. And what a great way to do it with a medication that is not, brand new, right? It's been around a while. It's got some, good safety data, right? And is delivering outstanding results.
So Beth, when we just talked about the primary endpoint, this composite endpoint at week 16, what happened with Level Up period 1 with the secondary endpoints?
Really, the key takeaway from these secondary endpoints, they're looking at EASI-75, EASI-90 as little as like week 2, right? They looked at EASI-75. They looked for that NRS of 0 or 1 as early as week 2. And even at that week 2 on just 15 milligrams, we had statistical significance, upadacitinib over dupilumab when it comes to this data. I mean, and it's a little disheartening. I'm going to tell you, I love Dupi, right? Dupi has been a game changer in the world of atopic dermatitis. Really, it's helped us define the spectrum of AD. So when I see data like this, I'm like, is that placebo? Right? It almost looks like placebo when you're looking at, an 8.2% of patients that are achieving EASI-75 at week 2, right? Or you're looking at 1.3%. Percent of patients that are able to achieve an NRS of 0 or 1 at week 2. So it's a little disheartening, right? I would expect that from placebo. And they could have been really mean because, the JAKs act really quick. So they could have done like a day 2, itch comparison, but they didn't. They actually, and that's when I tell patients you should start to see itch relief around, the week 2 mark with dupilumab. But I don't know if I can say that anymore, right?
Based on this data, it's very hard to say that because basically upadacitinib destroyed dupilumab at every secondary endpoint in this level up trial. And so when you talk about game changer, it looks to me like upadacitinib is the game changer here.
Absolutely.
Now, how quickly was statistical significance achieved for itch 0/1? I know you mentioned week 2, but it also looks like it was week 4, and it just kept going. Every time point after week 2 was statistically significant, separating upadacitinib from dupilumab for achieving itch 0/1. And the reason this is important is because itch is that most burdensome symptom in atopic dermatitis. And I guess, Beth, my question for you is, let's assume that a patient of yours has clear skin, but their itch is still 2 or greater. What does this data tell you about what you might need to do for that patient?
Depends on their medication, right? If they're on upadacitinib and they're on 15 milligrams, you better believe we're talking 30 milligrams, right? Especially if that itch 2 out of 10 is impacting sleep, quality of life, ability to focus, right? And then if they're on a different systemic, right, like a monoclonal antibody, right, then we're having a different discussion, right? Because as hard as we might try, nobody's going to approve an increased dose of a biologic, unfortunately. It's a sad truth. But that's one way where we have flexibility with, upadacitinib.
There you go, folks. You heard it from Beth Sweney right out of her mouth. She said that if a patient has clear skin and they're still itchy, you really should, after at least 4 months of a biologic therapy, itch alone is a reason to switch patients to a better therapy if your patient isn't fully responding. And I completely agree with what Beth said, and that's how I practice in my clinic. It's not just about the skin clearance, it's also about the itch relief. And either way, either one you can use to justify dose escalation of oral JAK inhibitors or switching from a biologic therapy to a JAK inhibitor. So, Beth, I want to ask you about other head-to-head trials, because Level Up is not the only head-to-head trial between upadacitinib and dupilumab. It's the one that used the on-label and started at 15 milligrams. But we also have data from Heads Up, right, which was the 30 milligram upadacitinib head-to-head with dupilumab. And what happened when you went back and did a post-hoc analysis looking at achievement of simultaneous EASI-90 and itch 0/1? What did that data show?
So even in the head-to-head study using the 30 milligram dose of UPA, they found very similar results, right? When you look at the post-hoc analysis, and they looked at the combination of EASI-90 and NRS 0 or 1, you had 12.6% of patients on dupilumab able to achieve that, and 32.7% of patients on UPA 30 milligrams that were able to achieve that endpoint.
And this endpoint, this composite EASI-90 and itch 0/1, I think it's here to stay. It really is representing a new standard of care, and it's really helping to differentiate these systemic therapies. And one of the ways we know that there's consistency, so we had consistency between the Level Up finding, upadacitinib over dupilumab. We have consistency with the Heads Up trial now that you just mentioned. And we also have all of these indirect network meta-analyses that are very consistent, that in terms of whether it's EASI-90, IGA 0/1, or itch relief, what we're seeing, the way I like to describe this, Beth, it's like the Olympics. The gold, the silver, and the bronze are all oral JAK inhibitors. None of the biologics are in those top 3 positions. And this speaks to the power, as you mentioned earlier, you called it game changer, right? The game-changing ability of these oral JAK inhibitors to treat skin lesions as well as provide itch relief. And I think that that's the nice inner consistency between all of these trials, as the indirect trials are now matching the head-to-head trials, even when you're talking about these stringent endpoints. So, Beth, we've talked here about Level Up period 1. Can you describe for us Level Up period 2? What are we looking at in period 2 that's different than period 1? And then we'll dive into that data.
Yeah, so period 2 started at week 16. So there was an assessment that they did. If patients achieved an EASI 75 on dupilumab, they were considered a responder, right? An EASI 75, 4-point reduction in itch, they were considered a responder. They were discontinued on the medication. They had a 12-week follow-up. But if they hadn't achieved that EASI 75 response and 4-point reduction in itch, then they were switched to upadacitinib 15 milligrams. Right. And then same thing for patients on upadacitinib. If they had achieved that EASI 75, they were considered a responder, right? That 4-point reduction itch, EASI 75. They discontinued the medication and they did a 30-day follow-up. And 30 days versus 12 weeks because varied half-lives, right? The half-life of UPA is significantly shorter than the half-life of Dupi. And then if they did not achieve that EASI 75, again, if they were on 15 milligrams, they were dose escalated, right?
So that's exactly right, Beth. So what we're seeing is that patients that were on dupilumab for 4 months that didn't achieve EASI 75 were put on upadacitinib 15 milligrams for 16 weeks. And let's see what that data showed. Beth, tell us, what's the take-home point? What did period 2 teach us about what happens when you switch from dupilumab inadequate responders to upadacitinib 15 milligrams?
I mean, this data is so impressive, truly. Again, we use that term game changer. I mean, this really is huge for patients. And that is that you have patients who did not achieve even a 75% clearance, right? We're not even talking the best of the best. We're talking they didn't achieve 75% clearance. That's like a low bar, right? On Dupi, right? And yet when we switch them to Rinvoq, now, all of a sudden, we have at week 20, right? So only 4 weeks later, we have 66.8. So almost 2/3 of those patients that are able to achieve that EASI 75 in just 4 weeks on upadacitinib, right? Not EASI 75, but all of a sudden now 2/3 of them are achieving that EASI 75. And then if we look even beyond that and we go out to week 32, we see close to 80% of patients that are able to achieve that EASI 75 on upadacitinib versus dupilumab. And then when we raise the bar further and look at our EASI 90 results at week 20, again, remember, these are people who did not achieve EASI 75 with Dupi. We have over 30% of patients at week 20 that are able to achieve that EASI 90 on upadacitinib. And then all the way out to week 32, we have close to 60%, right? 58.7% of patients that are able to achieve that EASI 90 on upadacitinib that could not achieve EASI 75 on dupilumab. And then when it comes to EASI 100, right, the best of the best in skin clearance, right, we have 8.8% of patients that are reaching that mark after only 4 weeks on upadacitinib, right? So going from less than a 75% improvement all the way up to 100% improvement in just 4 weeks on upadacitinib. And then we look out to 32 weeks, that 32-week mark, we see almost 20% of patients reaching that EASI 100 benchmark. And then when it comes to itch reduction, right, patients who are not responders to Dupixent or dupilumab, when we look at the EASI or the itch reduction, 4-point reduction in itch all the way at week 20 on upadacitinib, we have close to 60% or 58.3% of patients at week 20 and over 60% of patients at the week 32 mark that are able to achieve that. And then, of course, we know a 4-point reduction in itch isn't always good enough, right? For our patients, better is not always good enough. So then when we look at our NRS of 0 or 1 responders, that's really the money right there, right? When we're able to get that itch all the way down to 0 or 1. So these patients, we have 28.2% of patients that are able to achieve that at week 20 after only 4 weeks of UPA, and 37% of patients that are achieving that at the week 32 mark. But then when we look at the most stringent, right, we want to look at the combination of an EASI 90 and an NRS of 0 or 1, right? The most stringent outcomes for these patients, the one that's going to deliver the best quality of life for these patients. So these are patients that were not achieving anywhere near that when they were on Dupi at the end of that 16 weeks. So then when they switch to UPA, 14.8% of patients are achieving that simultaneous primary endpoint. And then at week 32, we have 26.8% of patients that are able to achieve that clearance in the skin and complete reduction of itch.
Pretty astounding results you just walked us through, Beth. And I think for me, if you're a provider and you have patients on dupilumab and they are not achieving a moderate treatment goal of EASI 75, over 1 in 4 of those patients are going to achieve EASI 90 and itch 0 or 1 if you switch them to upadacitinib 15 milligrams. This idea, this significant change from not hitting a moderate treatment target to achieving an optimal treatment target and minimal disease activity, it's really astounding. And it shows you how important it is for providers to be aware of the concept of therapeutic inertia and making sure that they are not stuck in the mud and keeping patients from achieving optimal outcomes. Now, Beth, one of the things that a lot of providers do, not just dermatologists, but internal medicine physicians and throughout all of medicine, we love to write for systemic corticosteroids. Now, I was part of a study that was just presented at a recent meeting where we analyzed systemic corticosteroid exposure in atopic dermatitis patients and identified that in a cohort of about 30,000 patients, what we did is we defined short-term, medium-term, long-term systemic corticosteroid exposure, short-term being approximately 30 days or less, medium-term a month to 3 months, long-term being up 3 months or greater. And what we found was that, first of all, 20% of all atopic dermatitis patients are receiving systemic corticosteroids. And of that 20%, almost 24% are receiving long-term corticosteroids, systemic corticosteroids. How is it in today's advanced systemic therapy world that of the 20% of atopic dermatitis patients getting systemic corticosteroids, a quarter of those are long-term? Beth, what does this mean to you, and how do you deal with systemic corticosteroids in your practice?
This makes me cringe. I'm going to be flat out honest. I am not a fan of systemic steroids, and I say it all the time. Systemic steroids in the skin are like opioids for pain, right? They're great for acute, right? If you've got a really bad case of poison ivy, sure, go ahead and get some prednisone, right? Short term, not going to have to do it all the time. But when it comes to chronic dermatitis, systemic steroids do more harm than good. And it's just, there's no place for it. Now that we have such amazing advanced therapeutics, there is no place for systemic steroids in chronic atopic dermatitis.
And Beth, what do the new atopic dermatitis guidelines from the American Academy of Dermatology say about systemic corticosteroid use in atopic dermatitis?
Yeah, so the AD guidelines, which that's fun to say, by the way. So those guidelines came out and they conditionally recommend against the use of systemic corticosteroids in patients with AD, right? They say maybe as like a bridge if a patient's really severe and you need help before they're able to get on to an advanced systemic therapeutic. But you really got to think about it, right? It's interesting though, because the AADAD guidelines recommend in favor of use, right? Strongest level of recommendation for both biologics and JAK inhibitors. And that means, what that means is that they're stating the benefits clearly outweigh the risks, right? So if they can strongly recommend JAK inhibitors for the use of AD and they're recommending against the use of systemic steroids, holy cow, we need to start putting things in perspective, right? What are we doing to patients?
Absolutely. Well, we know some of the side effects of systemic corticosteroids may include risks of immunosuppression, bone density loss, other metabolic, sometimes even psychiatric side effects. And Beth, this even extends to a study that I played a role in looking at the safety of JAK inhibitors compared to traditional immunosuppressants. And it turns out that JAK inhibitors are as safe or safer than traditional immunosuppressants like methotrexate, cyclosporin, but they're incredibly much safer than systemic corticosteroids. But yet the corticosteroids are still prevalent in use in atopic dermatitis, as I just mentioned. And we really, as a specialty, have to get away from that. And my personal belief is exactly what you said. It's cringeworthy that so many people are still using systemic corticosteroids. And if you're listening to us and you are using systemic corticosteroids, it is not standard of care to use long-term systemic corticosteroids. Now, you mentioned being on label earlier in our conversation, Beth, and certainly it is within the label of an oral JAK inhibitor to have a patient that maybe did a short course of oral steroids, and instead of keeping them on more steroids or longer steroids, just switch them to a JAK inhibitor. That is on label. Have you used that in your practice?
Absolutely. So a lot of my patients come to me having been given a round of prednisone by urgent care, right? Or their primary, just to buy them time so that they can get in, right? And seek dermatology care. But when those patients walk into my office, they usually like that prednisone, right? Like it's clearing it up really quick. And I have to tell them, look, you are not going to get more prednisone from me. I am not going to give you prednisone, but I will give you this medication. And so it's been wonderful to kind of bridge that with that systemic steroid and just transition them right in to an oral JAK inhibitor. And patients do really, really well on that.
Yeah, I would expect them to have very rapid skin clearance and itch relief with this approach. And Beth, I think one of the most important data trends that's occurred over the last year or two in dermatology has been actually the long-term safety data for the oral JAK inhibitors in atopic dermatitis, particularly upadacitinib and abrocitinib. And the long-term safety data, the way I like to phrase it, is it's safer and better than we could have ever hoped for when these drugs were first launched. And I think that this really reinforces there's a new standard of care. And in order to give our patients the best possible care, you have to incorporate advanced systemic therapies, both oral JAK inhibitors and biologic therapies into your regimen. And you need to minimize the amount of systemic corticosteroids, especially the long-term systemic corticosteroids that you're using.
Absolutely agree. There's just no reason for it anymore. So I think providers really, really need to acknowledge that, right? Acknowledge the risk of systemic steroids that we have known that risk for a long time, right? And yet the safety data that's coming out year after year, right? We have 5 years in upadacitinib now for AD, right? And so to be able to look at that data and see that, even though it hasn't had an oral surveillance study like Xeljanz has, like to know that with all the data that's been, accumulated on this medication across indications and on dosages that we can't even get, right? Because GI has like a 45 milligram dose, that there is still no safety signal, right? And that's super important, right? So there is no association between Rinvoq or upadacitinib and an increased risk of MACE malignancy, VTE, right? And death. So like that is super important when it comes to building confidence in having that conversation with patients.
I couldn't agree more. Now, one of the things that our listeners are probably wondering is, well, how do we switch from a biologic to a JAK? And my simple answer is, well, you can do it anytime if the patient's not responding. Now, you mentioned in the level up between period 1 and 2, when the patients were switching from dupilumab to upadacitinib, there was no washout period between period 1 and 2.
That's
and
correct.
To me, this is the right way to do the trial, because in the real world, I'm not going to say stop your dupilumab, we're going to wait a month or 2 months and then start your oral JAK inhibitor. No, these patients are suffering. I'm going to switch them right away to a different therapy if they're not hitting their optimal treatment target at probably about 4 months. And I say 4 months because the steady state concentrations in the blood of biologics occur around week 16. And we have in this Solo and Chronos clinical trials of dupilumab, we see that by week 16, dupilumab's largely plateaued in its clinical response. And I think that for me, I use around 4 months to make that judgment. So Beth, in your clinic, when are you deciding to switch from a biologic inadequate responder to an oral JAK inhibitor, and how do you onboard that patient?
Yeah, absolutely. So I also use that 16-week mark as that benchmark, right, in order to assess, are we controlled or can we do better? So if at that week 16 mark or that 4-month follow-up, that patient is still not meeting their goals, right, we are having that discussion. Do we want to continue because we know the likelihood of continuing to improve is minimal, or should we switch, right? So if I know I can deliver the patient better results with an alternative, why would I not talk about it? Right. So we're going to have that discussion. But I'm also not just using JAKs as post-biologic products, right? Like I'm offering them to patients along with the biologic, right? So if a patient's a candidate for both, we're talking about both right up front because they offer such different things, right? They both treat AD, but they do it in such different and really cool ways, right? There may be one patient for whom, one just happens to fit their life a little bit better. They may have certain comorbidities that fit one medication over the other. So I don't wait to have that discussion about JAKs just post dupilumab. I'm having it up front. I just think that's really important to note. I know it has nothing to do with this clinical trial we're talking about, but when it comes to switching them, I use that 16 weeks, that 4 months as my benchmark. We're having that conversation. And if at any point during their therapy, they're calling me and they're not happy, right? Let's say they're doing well at the 4-month mark, but a few months goes by, we have a season change and they start flaring again, right? I'm bringing them back in. We're going to have that discussion because there's no need to let a patient suffer.
Yeah, and I think you raise a good point there at the very end. No need to let a patient suffer. And I think that if you put yourself in the patient's shoes, what would I do if that were me or if that was my family member? Because if a patient is on a biologic therapy like dupilumab and they're an inadequate responder around week 16 or later, a lot of times, if it's a mild flare that they're having of their skin, right, you could throw a topical steroid on there. But the problem is that you're throwing topical steroids on to mask the fact that the biologic isn't hitting an optimal treatment target. And then what happens is patients may sit on these topical steroids for long periods of time, may overuse them, may not use them properly. And I think that, Beth, what you and I are arguing is that if you have a patient that's not achieving the goals, rather than slapping on a topical steroid, you really should say, well, these patients, according to the AHEAD recommendations, are not at optimal treatment targets. Therefore, I need to be aware of therapeutic inertia. I'm not going to let my patient stay on a medicine that's inadequately treating them and switch that patient to a different advanced systemic therapy. And what we're arguing from the Level Up data is that upadacitinib, as a representation of the oral JAK inhibitors, seems to have this ability to give patients or reach that optimal skin clearance or minimal disease activity better than dupilumab.
Absolutely. And the first patients that I got on the medication were patients that were not responding to dupilumab. Right? They were the very first patient. Dupilumab was our only option at the point, right? And then, Rinvoq came out and, we started writing it, and holy guacamole. It's great to see in the clinic for yourself a patient that has not responded all of a sudden have amazing skin clearance and itch relief on just a little itty bitty 15 milligram pill, right? It truly is astounding what we can do for patients if we just take that initiative to have that conversation with them, to identify the need that they have that we can't always see.
It's so important to actively reassess our atopic dermatitis patients sort of on that regular basis if they're on a systemic therapy, so that we can judge whether they need to be switched on therapies and avoid therapeutic inertia. Now, Beth, in your practice, patients that are on oral JAK inhibitors, what has your experience been in terms of the durability or maintenance or response to the oral JAK inhibitors?
Yeah, the oral JAKs have been very durable. I've had some train wreck of patients, right? I see a lot of patients that are hospitalized with erythrodermic eczema. So it's truly been wonderful to see those patients that are going in and out of the hospital, right? Season after season, getting really bad. All of a sudden, they're able to stay out of the hospital. They're able to maintain control, and they're able to do it in the long term. So even my most severe patients are having durable response to the JAK inhibitors. And one thing I love is that I'm very proactive about catching any little breakthrough that might be happening, right? You have some patients that come in and they know exactly when they're going to start flaring, right? Here in Michigan, we have some great seasons, but they come with some really big AD flares, right? So, you have that patient that comes in, I know exactly when I'm going to start flaring. Great. Let's meet up right around that time, see how you're doing. Guess what? If you have any breakthrough on upadacitinib, I'm bumping you up to 30 milligrams, right? I'll see you back in a month, see if you're well controlled. And then guess what? If you are, I can take you back down to 15 milligrams, right? So in that treatment really works in the long term as well, helping to kind of catch flares as soon as they start happening.
Yeah. So Beth, what you're talking about really is the real world use of upadacitinib and oral JAK inhibitors in patients. And it's very nice when real world data collected matches what's in clinical trials. And so I just wanted to cover with you a couple pieces of data. So one of the pieces of data that I presented at the most recent dermatology meeting was from the Comparative registry, which was looking at effectiveness of upadacitinib in moderate to severe atopic dermatitis after 6 months of treatment. And just to cut straight to the point, the optimal treatment target of EZ90 and ITch01 was met by 47% of patients at the 6 months. That is to me, a very tremendous thing when almost 1 in 2 patients is hitting optimal treatment targets and minimal disease activity. And it really shows how much JAK inhibitors are changing the atopic dermatitis treatment landscape. But if you think that's good, Beth, I want to leave you with one more data point. So there was an analysis looking at the long-term maintenance of optimal treatment targets for skin and itch with upadacitinib, a post-hoc analysis of the measure up 1 and 2. And what it showed was patients that at week 16 met EZ90 or met ITch01 or met the composite EZ90 and ITch01, how well did they maintain that response all the way out to 140 weeks? So if you believe that JAK inhibitors have this durable, maintained response, the answer is yes. They're not exhibiting any phenomenon of tachyphylaxis. So EZ90 was maintained. Optimal treatment target of EZ90 was maintained by 75 to 85% of patients, depending on the dose of upadacitinib. If you looked at the ITch01, it was maintained by roughly 70% of patients. And then if you look at the simultaneous EZ90 and ITch01 with upadacitinib, you're looking at around 60 to 65% of patients maintaining this to 140 weeks. And Beth, that speaks exactly to what you just said about the durability. Does this data surprise you at all?
It really doesn't surprise me. I mean, it's a phenomenal medication. I've been using it for a number of years. I even, started writing it before it was indicated because I had patients for whom the hospital was their next visit. Right. Cyclosporin was just barely hanging them on. Right. So I had to start writing this medication pretty early. And this really correlates with what I see in clinic. It's a durable response. Right. Rapid is one thing, but durability is everything. Right. Having that longevity of treatment and having a patient who is so happy with their treatment be able to stay on that treatment and stay happy. That's really, truly like what it's all about, right? When it comes to these chronic diseases.
Beth, it's been really absolutely a pleasure to have you here to be talking with you about atopic dermatitis. Neither of us have needed coffee because this is our coffee to talk science and atopic dermatitis. Could you please share your final thoughts or insights about Level Up Period 2 and what all of this optimal treatment target achievement really means to you, and what should our listeners take away?
Well, I really, really want listeners to feel empowered, right? When we feel empowered, we can empower our patients. So I really want all of you to feel empowered by this data, to feel empowered by the safety, the durability, the rapidity of response, and the ability that we have as providers to elevate the standard of care because our patients need it. And they deserve it. And now we can give it to them. And we can give it to them with real data, the most stringent data that's ever been collected on AD treatments. And we can identify patients who are subtherapeutic and be able to deliver them the quality of life that they deserve. So I really hope that you guys are seriously considering JAK inhibitors, utilizing them, and identifying, most importantly, identifying patients that might just need more, right, in order to achieve that quality of life they deserve.
Incredibly well said. And to all the listeners out there, this is our 6th episode on this podcast series program on JAK inhibitors for atopic dermatitis. And I'm really thankful that you've tuned in to all of these 6 episodes, including today's with Beth Sweney. And I really want to encourage you to think about this data. Think about what this data really means in terms of the advanced systemic therapy landscape and what it means for patients to truly have minimal disease activity that improve quality of life. And as Beth said, kind of the freedom to live their lives and not be burdened by atopic dermatitis. We as care providers in dermatology have to always put the patient first. And what we're now doing by elevating the standards of care is really putting the patients first. So with that, thank you so much for listening.
This concludes our program on JAK inhibitors for atopic dermatitis for now. Stay tuned to DermDocs for more dermatology education coming to you soon. Thank you.